Good afternoon. It's exactly 2 o'clock, so we're going to get started. I'm sure we'll have a few people logging in here as we go, but thank you for joining us today for our final session of our Dealing with Dementia series. We're going to be talking more about practical tools and approaches for caregivers today. I am Christine Drasher. I've been your host for the last couple sessions and will continue today. Thank you again for continuing with each session. We're excited to see the interest in these topics and hope we are giving you some good information. As you probably know from previous sessions, I am the Admissions and Marketing Director at Emerald Crest Memory Care Communities. We have 4 locations in Birdsville, Minnetonka, Shakopee, and Victoria. From before, I did go over what we offer in a lot more detail on the previous sessions. I'm not going to spend too much time on it today, but do know that on the handouts you'll have this information about Emerald Crest, how we are set up, our services that we provide, and then also a way to connect with our admissions manager, Elizabeth, if you're interested in learning more information about any of the Emerald Crest communities and set up a virtual tour. Also wanted to share information about CASIA. CASIA is our organization that manages and owns Emerald Crest, but also has several other properties within Minnesota. And then we also do have communities in North Dakota, Colorado, Florida, and Iowa. Again, we reviewed this at the last couple sessions, so I won't go into too much detail, but do know we have several different levels of senior housing that you can look into and look into your community to see if we have a community there on our website at casialife.org. We also have some community-based services as well with hospice, home care, pharmacy services, assisted technologies with what we call our learning lab, medical supplies, and rehabilitation therapies. So it's nice to know there are those branches of CASIA that you can utilize if you are still living in the community and also within any of our existing housing settings as well. Before we get started with our introducing our speaker today, I just want to go over a few housekeeping items. We have several individuals signed up for today's session, and to make it easy to answer questions, we are going to be doing it at the end of the session through the chat room. So if you can hold on to any questions that you have, and then at the end of the presentation, I will open up the chat room for questions, and Jenny will respond to those questions. We are also recording today's session so that we can have it available for those that have missed it or for those that are interested down the road. And so the best way for us to do that is if you can, if all the participants can remain muted and also remain with their videos off. It just records better if we don't have those distractions. So we'd appreciate if you would keep your mode with the audio and video off. All right, so let's get started today. We have a lot of information that we are going to be going through. Jenny and I reviewed the information a couple days ago, and we're hoping we can get it into the hour and a half that we have set for this. So I don't want to waste any more time. So I am going to go ahead and just get Jenny started here. We introduced Jenny on the first session about forgetfulness. Is it normal or a warning sign? Jenny is our Director of Cognitive Care at Emerald Crest. She's been with us for about 18 years and is a specialist in this field. As an occupational therapist, she works very closely with nursing staff and direct caregivers and families to really identify what challenges or gaps the individuals with dementia may have that they're experiencing due to their dementia. So I am going to go ahead and unmute Jenny because I'm sure that would be helpful. And then we'll get started here. So let's welcome Jenny. to the presentation. I unmuted you, Jenny. Did it work? There we go.
You hear me?
There you go. Thank you.
Okay, thanks, Christine. Good afternoon, everybody. It's nice to be back. So today, like Christine said, we're going to be trying to talk a lot about more practical caregiver tips as you caregive for your loved one and as you're going along on this journey in dementia care. So our two main objectives today with this presentation is first is trying to help you understand the changes caused by dementia related to, again, we'll kind of hit these main areas: communication, changes in their participation and ability with their daily cares and activities. And then we'll touch a little bit at the end of the presentation on behaviors and how we go about managing those in dementia care. Also, we'll be talking about becoming more familiar with common approaches used to provide care to individuals with dementia at each stage. So what approaches work best to care for your loved one as they progress through the different stages? So these first few slides, I'm not going to spend a lot of time. If you attended the last two presentations, a lot of this is very much review. It's just kind of giving you a little synopsis of what is dementia again before we dive in. So again, it is a group of symptoms that affects an individual's overall thinking skills. Like we talked about in previous presentations, it usually will begin with the higher level skills. It's not the bathing, dressing, and grooming that you see a lot of deficit with right away. It's going to be their ability to manage their house, manage finances, driving, maybe seeing more accidents, those higher level skills. A lot of these folks are still living, if you remember, in their own homes with just some minor or minimal assistance. The other thing we talked about is usually that first sign or symptom that's noticed by other family members or caregivers is that memory loss, because it's the easiest thing usually that we can see or that we can measure. But do remember, there's all kinds of different cognitive skills that are being affected besides just memory loss. And then, like I said, as the person progresses through their dementia, as they get more specifically into those middle stages of their dementia, that's when you start to see the person really struggle with the daily self-cares, the dressing, grooming, bathing, meals. And that's when family members, caregivers they tend to seek out more 24-hour supervision, more daily care, whether it's from a home care agency or having to admit their loved one to a facility, because that person just cannot be safe and live independently on their own. This also was a review from some previous presentations. This is that components of cognition, or that wheel of cognition that I talked about, I think, in the first presentation. Again, trying to give you a visual of, it's not just memory that's being affected when somebody is diagnosed with dementia, but look at all the different cognitive skills that are being affected. It's much more than memory, and it gives us an idea of how difficult and challenging it is for a person day in and day out that has dementia. And again, this was shown previously, but just trying to give you a more of a visual of, on the left side of your screen is that normal, healthy functioning brain. And then on the right side of your screen is a brain affected by someone that has been diagnosed with Alzheimer's. So you can see the difference. The Alzheimer's brain is almost shrunken, atrophied. There's those black gaps or holes in the brain where actual cell death has occurred. The brain is gone, and that starts to, as the person progresses, become more and more in the brain, and more skills are affected. And then we talked a lot about, once that person is diagnosed with dementia, then the next critical step for your healthcare providers is to figure out, okay, we know they have dementia, so now where in their dementia process are they? What stage are they in? And we kind of simplified it into early, middle, and late stage. And as I get farther into the presentation today, I'm going to break down that early, middle, and late stage and kind of go over some of the typical approaches, communication styles, techniques that work, I would say, the best with that early stage, middle stage, and late stage. So as we know, and part of the title of our presentation today is, we know that with the journey of dementia, it's all about the caregiving. And again, that's what we hope to provide for you today, is tips, tools as a caregiver. So along the way in a caregiving partnership. So I know everybody on the meeting today, I know we've all been on a road trip at some point in our life. When you think about a road trip, you have a driver and you have a navigator usually. So when I give this presentation to our direct care staff, the question I ask is, who usually in that caregiver relationship, who usually is the driver and who is the navigator? And a lot of times people will jump to, well, they'll jump right away to, well, the driver, that's the caregiver, that's us, which that's not true. It's the individual with dementia that's actually the driver. And then we as the caregiver are the navigators. We have to, based on where that person is in their dementia, they're kind of driving it. We then have to navigate based on what stage of dementia they're in. So they really are guiding us in how we need to navigate them. If you think about the road trip example, think about us being their GPS in terms of today and what we use in technology. So without our guidance, our caregiver guidance, they have the potential to become lost and fail. It'll be an incomplete road trip. So as we jump into practical tips for caregiving, the first area, and a very important area I always like to touch on, is communication, because it's really how we communicate with them that really kind of centers around our approaches and how we move forward in helping them to be as successful as possible. So again, some of this might be reviewed probably from Sarah's presentation last week on communication, so I'll kind of try to run through this pretty quickly, but just for a review, we know that with dementia, communication does change, and she probably talked about the term, or maybe talked about the term, aphasia. So with aphasia, what that means is what they say will change, how they say things will change, and how they hear and understand things will change. And if it wasn't talked about before, we know that there's two different types of aphasia. There's expressive aphasia, and then there's receptive aphasia. Expressive aphasia, or let's go back, receptive aphasia is when that person, for the most part, still has pretty good verbal skills. They still can express themselves pretty well. But the information coming in, the directives coming in to them, oftentimes that's where they start to struggle. They have a really hard time processing a lot of times what they're being told. You may give them a directive and you kind of, you see them give you that blank stare, and you can kind of see the wheels in the brain just turning, trying to figure out and process what's being said. And then they may respond, but they're very slow to respond. That's your receptive aphasia. And then the expressive aphasia is more probably what we're more familiar with. That's when the person not only is slowly processing and not understanding everything, but then they're having a hard time getting the words out. So these are the people that, again, are mixing up their words, can't find the right words, maybe repeating themselves or talking in circles. That's your expressive aphasia. And when you look at it in terms of early, middle, and late stage, that early stage dementia, they usually, like I said, you're not seeing the expressive aphasia. They usually, if you just talk to them, you probably wouldn't be able to tell anything's wrong. They can still verbalize their needs very well. But that decreased ability to understand, that receptive aphasia, that processing is starting to become impacted, or slower processing. As you get into the middle stage, that's when not only you're seeing the receptive aphasia, but now that expressive aphasia is becoming more noticeable. Difficulty understanding and expressing their thoughts and ideas. So starting to repeat themselves or having word finding difficulties. By the time you hit that late stage of dementia, they're progressed. They're going to have trouble. We call that global aphasia. They're going to have trouble all around, loss of written and verbal communication. And they're really now having to rely more on that nonverbal communication because they can't get the right words out, or they don't know how to use words anymore. Now, apraxia is another term that's important to understand when you're talking about communication and dementia. And again, I'm not sure if Sarah talked about this in the last presentation or not, but for those of you not familiar with the term, apraxia is when the brain does not consistently communicate with the body. So the performance of activities is variable. So what's happening is when a person is experiencing apraxia, their brain is not able to guide everything, their muscles, their joints, their lungs, their heart, everything is affected. The example I often use, and I see it all the time with the caregivers that I work with, let's say they're trying to get somebody to toilet. And they've got them in the toilet, and all of a sudden I hear, "Bob, sit on the toilet. Bob, sit down." And you hear that over and over, and you can tell that the caregiver is starting to get frustrated. And their voice raises, and it's, "Bob, sit down. Bob, sit on the toilet." And that person Bob is just standing there, and it looks like he's resisting the caregiver, but that's not what's happening. What's happening is apraxia. They're hearing, "Bob, sit down," but because of the disconnect in the brain, the wires are disconnecting, they can't get that message of sit down on the toilet or sit down from the brain to their muscles in their legs, their joints, in order to pull their pants down, bend at the knees and the hips, and sit down. They can't get that full message to the body. And so it's almost like they're frozen, and it comes off like they're resistive, and caregivers can get very frustrated with that. This is something that, you're not going to see this in the early and middle stages. You're going to see this come about more in the late stage of dementia, okay? So signs that an individual does not understand. These are very typical, and again, trying to give you practical tips. If your loved one or whoever you're caring for is repeatedly asking what, or I don't know, or what do you want me to do? Most of the time, they're not repeatedly saying what because they cannot hear. Now, could they have vision and hearing deficits? Of course, but if it's something that it's over and over and over, it's more so that they're not understanding or comprehending whatever you've asked them to do. So that's what you're going to get. There's been many times where I've been in the bathroom with somebody, helping them get dressed for the day. And even though the clothes are right in front of them, visible to them, they still will look at me, and they'll ask me, "What do I do next?" I'll say, "Okay, Bob." I'll hand him the shirt. "Put your shirt on." He puts the shirt on. And even though the pants are right there, he'll again look at me and say, "What do you want me to do?" He doesn't know the next step or what to do. Another reason, a way to tell they don't understand, is they'll walk away from the interaction, especially in the late stage. Their attention span is very minimal, sometimes not more than 5 minutes, if that. And if they're not understanding it, what do? They walk away. They escape. It's their way of dealing with too much information. They may become verbally or physically agitated, whether it's raising their voice and yelling if they don't understand, or a lot of times also in the late stage, because they don't know how to communicate with words anymore, they might get physical. They might hit out. They might push you away because they don't understand. Another thing I've seen a lot of, they may cover their ears, their eyes, they may put their head down. A lot of times when I'm working with dementia, I see a lot of some of the behaviors that they do and not understanding. It's very equivalent to a small child or a toddler. Any of you that have raised kids, what do they do when they're frustrated, when they don't want to do something, or they, again, don't understand? What will they do? They'll put their head down. They'll kind of shut you out. I'm starting to even see some of that in my 15-month-old, he will do some of these things. It's just too much. They don't understand. So, you know, I think some of them are kind of common sense, but some, I think, good dementia communication techniques to keep in mind. Individuals with dementia, remember this now, this is important, they will focus less on the content of what you say and more on how you say it. 90% of what you say isn't coming out of your mouth. And that is so true, no matter what stage a person is in, even if they're in the later stages of dementia, they pick up on, let's say, your attitude or your tone. And I tell this to caregivers all the time. When you come in to start your shift, maybe you had a fight with your spouse or your kids, or you're just having a bad day. If you come into your shift and you come in with all that anger and that frustration, guess what? Your loved one, your residents, they're going to pick up on that. They're going to know, and guess what? They're going to mimic that. If you're frustrated, if you're angry, if you're on edge, they're going to be frustrated, angry, on edge. So that is one of the biggest techniques I can give you, is you've really got to watch your tone, how you deliver the information. Making eye contact. Now, this is huge, especially when you're getting into caring for folks that are in the middle to late stages, because you have to remember, as they progress, they understand less and less verbal communication. So they're going to start to rely more on that nonverbal, and eye contact is huge for that, to make that connection with them. Getting at their level. And again, as a person progresses, they start to become, almost have more of a shuffled gait. They start to look downward. There has been times where I've been trying to communicate with somebody in those later stages, and I've actually had to get down on my knees and get at their level, where they're seeing or where they're looking, where their visual field is, in order to make a connection and try to communicate with them. You may have to repeat statements when necessary. Like I said, they're not understanding, or they're slower to process. So you might have to give the very simplified directions a few times before they actually can understand it. However, keep in mind, when you are repeating stuff, you need to kind of know or have an idea when to actually redirect it. If you've got somebody that's very anxious in the late day because they think they need to get home to their kids, or their mom and dad is looking for them, you know, you can redirect them. You can, you know, if they're asking where mom and dad is, you know, tell them mom and dad are at work. I mean, you can repeat that a few times, but you don't want to keep going with that over and over and over. At some point, you want to get them onto something else, change the subject, ask them a question, get them off of that topic, because if they continue to perseverate on something like that over and over and over, it will actually cause more agitation and anxiety. So that's important, knowing when to reapproach, knowing when to redirect it. Speak slowly and stay calm. I think sometimes that's common sense, but we forget it a lot, especially when working with someone with cognitive loss. You know, we're in a society where it's go, 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 go. You know, we need to get on to the next thing. We can't do that with somebody with dementia. They are slow to process. You have to have the time and take the time with them, or it's not going to work with communication or caring for them. Don't argue, correct, question, try to convince or reorientate them. And I know this is tough. I've seen family members struggle with this. You know, they think it's summertime and it's the middle of the winter, and you know, I've seen family members try to correct them. At some point, that doesn't help. We say live in their reality. So if it's you know, summertime to them, then ask them, you know, what they like about summer. You know, go with them, live in their reality. Don't try to correct them, because that'll only confuse them more and agitate them more. Always be respectful. I think that's common sense. We always want to treat our residents with dementia, our loved one, how we would want to be treated. So as we dive in more here, let's get into care delivery. What does that look like at the different stages? So some care delivery essentials, there can and there should be a method to it. It should not be, well, I'm going to try this approach today, I'm going to try that approach tomorrow. You want it to be, when you're caregiving and giving them approaches, you want them to be as predictable and reliable as possible. They should not vary from day to day, and it should not vary from one caregiver taking care of them to a different. The way that we kind of guide our caregivers at Emerald Crest is we try to train them on the same approaches, and those approaches should be used with each shift that's caring for that resident, and each caregiver should be using those same approaches or methods. So, role of a caregiver in delivery of cares. Well, one, as a caregiver, we're compensating for the physical skills that are impaired or missing, but also, and in addition, and very important, is we're also compensating for the cognitive skills that are impaired or missing. So when you think about caregiving, think about being on a bridge, and you're going down that or across that bridge, and all of a sudden there's a gap in the bridge. Well, how are you going to get from one side of the bridge to the next? How are you going to get from A to B? Our role is, as a caregiver, is we're filling in those missing pieces or gaps. So just like the bridge example, it might look different. So somebody that's in maybe the early middle stages, it might be that we just have to go in and give them the verbal cue to get up for the morning, or we may just have to lay out their clothes and then they can do the rest. Versus somebody that's in the later stages, we might have to actually physically stay with them and physically help them with all the different steps of dressing, grooming, or whatever you're helping them with. So how you fill in those gaps is going to look different based on what stage they're at, but that's our goal, is we're trying to fill in the missing pieces or gaps. And we're not just going in and doing it all for them just because they have dementia and they have poor memory. We're assisting them, again, depending on what stage they're at, to reach their desired goal, but we're still having them participate to whatever level they can. So what I want to do now with these next several slides is I want to break down the different stages of dementia, and I want to talk about what typical approaches or techniques work best in guiding somebody with cares at that stage. And what I want to say before I jump into this isn't a cookbook type of thing I'm presenting here. It doesn't mean that everybody at early stage always follows these techniques. This is just in general what tends to work best in guiding them. So keep that in mind. So with early stage dementia, and if we think back, again, I'm kind of referring back to some of the information we went over in some of the previous presentations. If we correlate these early, middle, and late stage with, if you remember, the Allen cognitive levels, this early stage is very similar to the Allen cognitive level 5. Again, these are people that most likely are still living in their own homes, living out in their own community with some minimal assistance maybe, but for the most part are able to do their day-to-day cares pretty independently. With these folks, with communication, for the most part, you can give them, simplified verbal directions and they can follow it pretty well. Meals, you're not really going to probably see a lot of deficit in the area of meals. It's basically, the biggest thing is just making sure they remember when to be eating their breakfast, their lunch, their dinner, that verbal invite or reminder, just making sure they're set up and they have what they have, or have what they need. And then after that, they're usually fine. No other issues with eating and meals. When you get into grooming and dressing with early stage dementia, verbal reminders to start is usually what they need. So just that basic cue, it's time to get up. They need that alarm in the morning. They usually, when they're directed, they can go to the closet. They can make appropriate choices in dress. They can go into the bathroom and they can, use grooming supplies appropriately. They just need that kind of reminder, that push to start. Bathing is going to be more of a setup and supervision. So making sure that not only are they bathing on a frequent basis or consistent basis, but they're safe in doing it. So again, physically and cognitively, for the most part, once they're in, they probably can go throughout the washing, just fine. But it's just supervising for safety, falls, and making sure they at least, are frequently bathing. Now, as you jump into the early middle stages of dementia, again, if you remember those Allen cognitive levels, this is going to be more now you're into your fours, your maybe mid to high fours or low fours, right in there. Communication, again, they can follow verbal directions, again, simple, and showing them a sample, of what you want to do is always helpful. With meals, again, not a lot of issues in this area at this point, still setup and supervision. Again, so reminders of when breakfast, lunch, dinner is, and then just making sure that they're set up and that they're supervised, that they don't run into any issues along the way, but usually can eat with utensils just fine, regular plate, all of that. When you now get into grooming, dressing, and bathing with the early middle stage dementia, you're going to see that they follow best what's called setup and supervision. So again, these are the people that if you ask them to physically put on a shirt, brush their teeth, physically they can do those things. But where these folks start to need help is with the quality and the completion. So if they don't have somebody actually getting them started, maybe putting out their clean clothes or making sure their toothbrush is out with the toothpaste, these are the people that will, without that help, they will maybe put on the same clothes for a week straight, dirty clothes over and over and over, or they may forget completely to brush their teeth or not use the toothpaste when brushing their teeth. They're gonna forget that quality, that fine detail. So that's what that setup and supervision means. Now, with these folks, if you're caring for them, you don't necessarily have to be there step by step by step. You can get them started with the supplies they needed and then maybe just check back with them to make sure they don't run into any problems, but you don't have to be there every second. The bathing, same thing, setup and supervision. However, with bathing, I often tell caregivers, be there the whole time because you start to run into fall issues and that can get dangerous. It can be a safety issue. But setup and supervision, again, once they have the washcloth, the shampoo, the body wash, once they're set up with the right supplies and given the cue, they usually can do just fine from there. Now, a little bit about setup and supervision. I probably have gone over most of this already. Why do we do it? It gives them a verbal cue to get started. It's making sure they have all those supplies because they will forget those details. It's, if possible, lay out the items so that they know exactly what they should be wearing. If they just take their clothes off at night and then put them over the end of the bed or the chair, guess what they're going to do? If they get up in the morning with no assistance, they're going to look to see, oh, I've got clothes there, not knowing that maybe they've worn them day in and day out, and they'll just put those on again without somebody actually setting them up with the clean clothing. Provide supervision to assure quality and completion, like I talked about before. And like I said, it's something where you can get them started and then just check back. Now I'm going to jump into the middle stage of dementia. So again, if we refer back to that Allen cognitive level stage, now we're kind of entering into the level 3s on that 6-point scale, the higher 3s. So with this, it's more that, again, simple verbal directions like before, but a little bit more demonstration of what you want them to do. Not just here, go ahead and do this, but show them what you want them to do. Meals, again, for the most part, and this isn't cut and dry, it doesn't mean with everybody at this stage, but most of the time when it comes to meals, again, if you just set them up with the right utensils, plate, everything, they can do pretty well with some supervision. Now, grooming, dressing, and bathing, you're going to see what's called setup, not only setting them up, but now step-by-step directions. And what you will see as the key difference between this middle stage and that early middle stage I just talked about is you have to stay with them now. It's not just, here's your clean clothing, here's your grooming supplies, I'll check back with you. It's, you're helping them to set them up with those supplies, but then you're also staying with them and kind of giving them cues of what to do next, because they're going to start to have trouble with some sequencing and not always maybe know what to do after you put the shirt on or what to do after they brush their teeth. So that step-by-step directions and staying with them the whole time. If you leave, a lot of times they will falter very quickly. They will not know what to do, so they may go back to bed. They may say heck with it altogether. So again, the reasons why we use the step-by-step technique for this middle stage is, again, you got to stay with the person. That's the big difference, to guide them through every step, guide the individual through each step. Remember the order and parts of the care. So like I said, sequencing is beginning to become a problem. They don't remember every piece of it or what order. That's why they need you to stay there. Complete all parts and care with quality, and then monitor the speed. And what I mean by that is I've had residents that I've went out and assessed, and maybe they're living in their own home, and I've had family members say to me, gosh, it can take them up to 2 hours in the morning to get dressed. And they can't figure out why. Well, why do you think that is? If they're just been given, left alone and maybe given some clothes and that's it, they don't know what to do. They need that step-by-step direction. So that's why it can take that long. So having somebody there, staying with and giving the step-by-step techniques can really help that person move along in the day with their cares. Now I'm going to move into the late middle stage. So again, I'm kind of using those Allen cognitive levels too. So now I'm kind of moving into that middle 3.5. So if you look at communication now, it's not just giving verbal directions with some demonstrations. It's now giving communication in a very one step at a time, short, simple statements. If you give a person at this stage a long, drawn out set of directions, they're going to get lost after the first step. So it's really breaking it down. So first we're going to do this. Now we're going to do this. It's making it as simple as possible when you're communicating with them. Meals, you're going to see a difference now. A lot of times when people start to progress into this stage, to give them just a regular plate of food all at once is very overwhelming. You may see them just sit there. You may see them sit and stare at it. You may see them just pick at the food. You may see them get up because it's overwhelming. They don't even know where to start. So one item at a time, what that means is we can take a meal. Let's say you're having some chicken, potatoes, and vegetables. We can break that meal down. We start with the protein, we start with the chicken, and we just put it alone on a smaller plate. Present that to them. Have them try the chicken. And then once they're done with the chicken or almost done with it, you take that plate away and then you bring out the vegetables. Have them work on the vegetables. Then bring out the third course, whether it's potatoes or whatnot. That way you're breaking down the meal. It's more doable and you're more likely to see them eat a little bit better, okay? And if you look at grooming, dressing, and bathing here in the late middle stages, same type of thing. You're going to be staying with them again, and you're going to hand them. It's not just, okay, do this now, do that. Now you're actually physically handing the shirt to them, the pants to them, the toothbrush to them, and then giving them the cue of what to do. The reason we do that is we're trying to focus their attention on the objects. They may start to have difficulty knowing how to use the objects. So being able to hand them and tell them what to do can help with that. And like I said before, you can control their speed.
Scout, come here. Scout, Scout.
Now as I jump into the early late stage of dementia, we're talking probably those low 3s on that Allen cognitive level. Again, when it comes to communication, it's going to be one step at a time directions or hand over hand assistance. So now it isn't going to just work to give them verbal directions, but you're also going to have to physically hand them what you're trying to communicate. So you're going to start to see in that early late stage of dementia, it's not just about the verbal cues, but you're also having to step in more physically to guide them. So if you look down at grooming, dressing, and bathing, you're going to see what's called caregiver starts, individual finishes. So if we jump to this slide of why do we use caregiver starts and individual finishes, it helps give the individual time to understand the care. So the big thing that happens in the later middle stages is they start to lose the understanding or the how of how to use objects or what objects are used for. So this is the stage that you might see your loved one take a fork and use it to comb their hair, or take a toothbrush and use it to shave their face. I just saw that recently with a person I was taking care of. It's because they're not knowing how to use the objects. So what we often will do with, say, like dressing, it's not just here's your shirt, put it on. It's I might start one sleeve for them and then let them try the other sleeve. I might start the pants for them and let them pull it up. What you're trying to do is give them time to understand the care. You're giving the brain time to connect the dots. So by the time you start the pants, they're hopefully getting it, oh, we're putting our pants on, so that they can then help to pull it up. You're doing that because you don't want to just do it all for them. You want to try to maintain as much function as possible. And by you allowing them to still participate, they're going to be more cooperative. A lot of times in that later stage here, if you just jump in and just do everything for them, a lot of times they can get agitated with that and actually get physically or verbally resistive. So it's helping maintain function and promote cooperation. One technique I do want to touch on real quickly is start at the feet and work up. This is a specific technique that we often use in those later, middle, late stages, because at that stage, if you're going to have resistiveness, usually it can be physical, because if they're in any kind of distress or they don't understand, they can't verbally a lot of times voice that anymore. So it comes out as whether they're pushing you away or hitting out. So starting at the feet and work up. Why we use that is it helps, again, to prevent or decrease any kind of resistance, and it limits feelings of fear by starting at an area of the body that is least intrusive and gives the resident time to understand the care at hand. So if you think about it, if you're bathing somebody, that's a very vulnerable thing for them anyway. If you go in and you just start immediately, like say undressing their top or taking their pants off or washing their upper body or their private parts, guess what? Anybody, let alone somebody that doesn't understand, is going to be very fearful of that. They're going to, put up their walls. But if you start, say, at the feet and just say, let's take your sock off, let's take your shoe off, let's soak your feet. The idea is by the time you get up to the areas of the body that it might be more intrusive or more private, the idea is by that time, your hope is that, again, the wires have connected in the brain and they're understanding that you're helping them bathe or you're helping them dress. So start where it's least intrusive. That's the idea behind this start at the feet and work up. So now, I think you need to go back to late stage dementia. There you go. So now let's end with late stage dementia here. So now we're really entering into the level 2s of that Allen cognitive level 6-point scale. So when it comes to communication, it really is one-step directions. These are the people that aren't really understanding verbal communication or words anymore. So it's a lot of having to guide them with your hands, touch cues, sit here, come with me. Very, very simple. Meals, not only breaking it down into the one thing at a time presenting to them, but these people a lot of times will start to not know how to use a fork, a spoon, utensils like that. So in order to try to maintain as much function as possible, we may go to finger foods. So putting a piece of chicken between 2 pieces of bread so they can pick it up as a sandwich, giving them maybe fruit or anything they can pick up with their hands so that they still can be independent as possible. They can still feed themselves, and we don't have to go right to feeding them. You're going to see with grooming, dressing, and bathing, it's the caregiver is really starting the care, and they're really doing physically and cognitively most of it. They're helping move their body because they may not know how to move their arms and legs anymore. You're helping them hold items because they may not know how to do that. It's really almost becoming total care a lot of times at that point. So that whole idea of the care partner completes the cares, why are we using it at this point? Well, like I said, they're losing or they've lost the understanding or the process of cares. They, at this point, probably don't really know how to use objects anymore. They, again, like I said, can't communicate verbally anymore. And not only is the verbal being affected, but now even coordinating their movements, knowing, remember that apraxia that I talked about? They don't know how to move their body anymore. So a lot of times physically, then we have to help and do much of it. So now these next couple slides are just kind of some quick tricks of the trade. So mealtime, and I've talked about this a lot already. You're really going to have to or want to simplify the setup, whether it's going to one item at a time or finger foods or whatnot. Simplify. Serving small portions. If you don't have to go to one item at a time, sometimes just giving them smaller portions. A lot of times what we use is called a divided plate. So it's a plate that has 3 different sections, and just doing that alone and putting a small bit of each food item in those sections can make it look a lot less overwhelming to the person. And this is always a good trick. If you're having trouble getting your loved one to eat, a lot of times just adding a little sweet to it, whether it's syrup on something or ketchup or jelly or whatever it is, a lot of times you can see that will help them eat. We all like sweets, right? And I talked about finger foods already. Dressing, tricks of the trade. Loose fitting clothing. A lot of times I recommend this a lot to my family members, is you want to find clothes that are easy to get on, easy to get off. You don't want tight fitting pants or jeans with zippers and buttons. You want elastic bands, whatever's going to make it easier and simpler and less agitating. Unnecessary steps. I know some family members can be difficult for them to get to this point, because let's say dad always dressed, with the tie and the button-up dress shirt or the white undershirt underneath. But a lot of times when especially in the later stages, when you have somebody that's very apraxic, isn't moving, isn't following directions, to have to add extra layers like undershirts, bras, different extra layers, that can make it very difficult and agitating to them. So if we can eliminate any of those things and still have dignity for the person, I always recommend that. Multiples of the same outfits. So if they're really, stuck on wearing a particular outfit and they end up re-wearing it throughout the week, get them 7 days a week of that same outfit, and then that way you can switch them out and they'll never know. Adaptive clothing, those of you that aren't aware, we use that mostly with the people in the late stages of dementia. It's clothing that we use a company called Buck and Buck. It's clothing like shirts that button in the back, so you don't have to pull it over their head, which can be very agitating. Or it's pants that zip up the side or button up the side, so that if they can't stand anymore and you have to dress them in bed, you just have to pull it to the knees, and then you can just zip it up the rest of the way. And definitely we can get, if it's something that would be helpful for you, like I said, Buck and Buck is a great resource for that. Bathing, like I said earlier, bathing is probably the hardest, most difficult care for caregivers to complete with their loved one that has dementia. Time of day the bath or shower is offered is really important. You have to remember with bathing, there's a lot of steps involved, and it's very intrusive, invasive. They're cold, they have no clothes on, and they're confused. So you can imagine how tricky that bathing can be. So time of day, I always tell staff members, if you tried, let's say somebody was used to always taking their shower at night after dinner and before they went to bed, and now it's 7 a.m. on a cold January morning and you're trying to get them into the shower, are you going to probably run into issues? Yeah. So it's looking at that history. come with me. I never use the word shower when I'm working with somebody with dementia. That's a lot of times going to set them off right there. So it's the biggest trouble is getting them to the shower. Once they're in the shower, a lot of times it's easy after that. But just come with me a lot of times is enough to get them there. Like I said, bathing history, method, and frequency is so huge. So knowing, you know, how often they usually did take a shower is key. Crank up the heat in the bathroom. We know how cold we get when we take showers. That's key. Using a bath bench, you know, no matter how mobile your loved one is, I always try to encourage sitting down in the shower for that safety. They can be very unsteady. Wash the hair last. I tell caregivers this all the time. If you start right off the bat and soak their head with water and shampoo, you're probably going to have a very agitated individual. It's going to be really hard to complete the rest of the washing of the body. So I always end with that. Spa day, I try to really kind of fluff it up. You know, I'm going to pamper you today. You're going to get a foot soak. You're going to get a massage. Make it positive sounding. Water pressure is key. You know, some people like a harder pressure, some light. You got to really look at that. Temperature, you want to make sure, again, heating the room. If you warm up the towel, sometimes that helps. So just some tricks. Grooming and hygiene. A lot of times it helps, and I know we use this at Emerald Crest, to have a grooming box. So just having a container that just has their essentials as far as toothbrush, toothpaste, comb, lotion, so that you just don't have all kinds of stuff sitting on that bathroom counter to confuse them more. So keep it simple and just pull out what they need. Removing mirrors. Sometimes having that mirror in the bathroom can be quite agitating, especially to people that are in the later stages that might be hallucinating or delusional. They look at the mirror and they don't recognize who that person is. So maybe removing those. And again, like anything else, you got to simplify the steps.
Hey, Jenny, can I just ask a real quick question that came over on the chat, because I think it's just timely?
Yep.
Somebody asked, how often are baths and showers necessary?
You know, I don't know that I'm going to say that there's any number of showers that are necessary. You know, I use Emerald Crest because that's where my experience is. We provide 2 full showers a week, and then just kind of spit or sponge baths the other days. You know, I would say for someone, most of these people at the age that they're at, you know, a couple times a week. But I'll be honest with you, if you have somebody that it's really tricky to get into the shower, I will tell my caregivers, if we can do baby steps, if we can even get them into 1 shower a week and just spit baths the other days, that's a success. Biggest thing is you want to watch for any kind of skin breakdown and that type of thing. And I think it also depends on how incontinent the person is too, because the more incontinent they are, you have the potential or the risk of skin breakdown. And that kind of goes into incontinence now, tricks of the trade. So helping somebody with toileting, signs on the bathroom door, that can help. And again, you got to make sure that they still understand symbols or words, but sometimes even directing them with a picture or some type of signage can help. Colored toilet seat, a lot of times I've found that to be helpful for my men that maybe still stand up to urinate, having that toilet seat to differentiate it from the rest of the bathroom or the rest of the toilet. A raised toilet seat. Now, why I recommend that is a lot of times, remember that apraxia I talked about? Can you hear me? Okay. That raised toilet seat, a lot of times with that apraxia, again, they don't know how to sit. And so if you have maybe a toilet seat that's higher and they don't have as far to go from standing to sitting, that can help. Hiding the trash cans. Why do I say that? Well, as you get into the later stages specifically, you can have people that may urinate in inappropriate places. So a lot of times, a trash can, that looks like a toilet. So you may have to hide that so you don't have them doing that. Having them on a toileting schedule. Pretty typical, like for our residents at Emerald Crest, a lot of them are on a 2-hour toileting schedule where they're invited or brought to the bathroom every 2 hours. That helps with incontinence if they're regularly getting to the bathroom. And jumpsuits, I will touch on that. We try not to use those a lot because in the care facilities, they can be considered restraints. But if it is bad enough and nothing else is working, in the past, we've used what are called jumpsuits. They're one-piece jumpsuits that maybe zip up the back or button up the back. And they can help so that the person can't basically get the clothing off as quickly to urinate inappropriately. But again, that usually is a last resort for us. We don't use those a lot if we don't have to. Tricks of the trade for medication. A lot of times if I'm having trouble getting somebody or somebody's refusing to take medications, a lot of times I'll say, here you go, here are your vitamins. I say vitamins because a lot of us, many people took those throughout their life. So that's something they're familiar with. Or sometimes just saying your doctor asked me to give these to you. That doctor or that person of authority, they may just take them a little bit better if you use that type of approach. Sometimes we do have to hide them or crush them in different types of food or drink to get them to take it, whether it's applesauce or ice cream. And then, like I said, some people can't, when you get to the point where they have trouble swallowing, you might have to get an order from the doctor or be able to crush the pills so that they can take them better. Just some safety tricks of the trade. Falling is a huge issue with our elderly, especially our elderly with dementia. So you really want to take a look at your environment and set it up to be as safe as possible for your loved ones. That means decluttering. That's huge. Decluttering is making sure that you're removing any extra furniture. Those throw rugs that we all have in our house, those are probably the worst thing you can have for people with dementia that are having more trouble with their ambulation. So removing those, floor mats, all of those things. Assistive devices, having those when needed, whether it's a walker, if they still know how to use that, wheelchair, alarms, that those can be helpful too in keeping a safe environment. You may have issues with somebody eloping or wanting to leave the building or the house. So having bells on the door to alert you if your loved one is trying to go out the door. Or again, if they can still understand words or signage, having a stop or a do not enter sign. Or even turning the lights out in certain parts of the house can help them from eloping or going out outside. Wandering, that's a typical thing you see with people as they get into the middle or later middle stages of dementia. So what you want to do the best you can to help use up that energy. So even having a consistent walking program where you walk with them certain times of the day can really help with that. So the job of a care partner, again, just some summary type of statements here. Again, we're trying to fill in those gaps, and that's going to look different. Takes skill and practice. This isn't something where, you just learn. You kind of have to really know your loved one and kind of figure out what works and what doesn't. It's not obvious to the individual. So how you're filling in those gaps and helping them, a lot of times they don't even realize how much or how little you're helping them. Allow for successful completion of activity. And we want to make sure that we're always staying calm, consistent, open, and creative, and simplifying. Simplification is the name of the game. So now, as we get towards the later part of this presentation, I want to jump into activities because that is key when you're working with somebody that has cognitive loss, has dementia. So when I think about activities, when someone is living with dementia, they still identify with their lifetime roles and seek out meaning and purpose. So just think about yourself. You all have hobbies. You all have things that are important to you in your life. I think about myself. If I'm 80, 85 years old and have dementia and in the memory care, golfing is a huge passion of mine. I would hope that maybe I could be set up to do that to some extent, you know, not getting out on the course maybe, but maybe they have a putt-putt green set up for me. You know, it's keeping those specific hobbies, interests, some way in your routine, in your structure. And that's what we strive for with our folks that have dementia. So activity planning. So whenever you're trying to figure out activities for your loved one or a structure or a routine, you want to really figure out a fine balance between enough stimulation and overstimulation. So a fine balance of activity and rest. It really is trying to find purposeful activity versus noise. You're not just trying to fill their time with nonsense type of activity. You want it to be purposeful if possible. The goal in mind when creating stimulation is remember, it's for your loved one, it's for the person with dementia, it's not for the caregiver. I've had caregivers come up to me and say, I am really tired of having to do this game or bingo every single day. Well, for us that are cognitively intact, yeah, it probably would get pretty boring. But for somebody with dementia, they're not necessarily going to remember that we played that game yesterday and we're playing it again today. So again, we have to keep in mind what is needed for our person that has the cognitive loss. Routine and structure provides feelings of, again, control, familiarity, sense of purpose or meaning for them. It provides them safety and security, a consistent routine, and relief. If they don't have to be figuring out what they're supposed to do in their day and they have structure, it's going to cause them a lot less anxiety. So let's again kind of break down these stages and what works for activity at those different stages. So again, talking the earlier stages, tasks that they do really need to have a clear purpose. These are folks that are pretty high level still. So they most likely still can do reading. They can write. You can have full open-ended conversations. So it's not just yes, no type of answers. It's, you know, tell me a little bit about your childhood. Tell me a little bit about your job as an electrician. And they might be able to talk about that. Imagining, able to think more abstractly. When you're really thinking about setting up activities for them, it's really looking at what can they attend to. And these folks usually can attend pretty well to something for a good 45 minutes to an hour. And tasks can be more multi-step, 4 to 5 steps at a time. As you jump into the early middle stages, you're going to want to look at tasks that are more simple now and have a clear ending to it. You know, you can still have some discussion, some reminiscing, but you're going to start to focus more on what can I give them to do, to manipulate. Tasks with no more than 4 steps. And again, their attention isn't going to be as long before they need a break. So you're going to have to break it down into more, maybe 30, 45-minute steps. Objects have meaning. You want a concrete, clear ending. So what I mean by that is you can't start something, let's say you're making a birdhouse and one day you're just going to sand it and the next day you're going to paint it. For somebody at this stage, that's going to be frustrating to them. They're going to want to have a clear product in the end, or if you try to present something to them that they started the day before, they're not going to remember it, and it can be frustrating for them. As you get into the middle stage, you're going to want to really focus on more familiar tasks, things that they maybe did much of their life. Tasks with 2 to 3 steps, again, only 20 to 30 minutes now in length. Now, these are the folks that, again, you have to remember the communication. They're not able to find their words or communicate as well. So less talking type of activities and really focus on the doing. Step-by-step directions. This, again, just like with the cares, you can't just set them up with an activity and leave. They're not going to have any success. You have to stay with them and step them through. You'll see some pictures here, you know, folding activities are really good. Sanding, sorting silverware, real familiar tasks. As we get into the late middle stages, you want to really focus on repetitive use of objects. So again, maybe doing something where it's only 1 or 2 steps and you're doing the same motion or task over and over and over. Again, remember their attention span is now less and less and less. So you don't want to be doing things for long lengths of time, just real quick, you know, activities here and there, 15, 20 minutes. You'll see in the picture below, rolling yarn if they were a sewer, or if they were a woodworker or did a lot of little household projects, maybe just sanding a piece of wood. They may, this is the stage where they may not know how to use objects appropriately. So you're, again, going to have to be there and give constant supervision. This is the stage where you got to be really careful, because anything you give as an activity, it may go right in the mouth. So you want to be careful of using small objects when you're doing activities. Now with late stage dementia, when you're doing any type of activity with somebody in the true late stage, you want to focus on those senses, things they can touch, things they can taste, smell, things they can look at or feel or listen to. Music is huge. It's all focused on objects. You're trying to engage their senses, alert them. One step. You can't have these long drawn out activities. Their attention span at this point, 5 minutes, maybe 10 minutes if you're lucky. So it has to be just really small spurts of activities. This last section I want to go over here today before we end now is behaviors. You know that if you've cared for somebody with dementia, you know that behaviors is part of that dementia journey or that process. Some people may have more intense or severe behaviors than others, but it's probably something you're not going to get by. You're going to have to figure out how to manage. So a behavior, basically with somebody with dementia, it's a method of communication of a need that's not being met for the person. And remember, they can't communicate like you or I, so it comes out as a behavior, and a lot of times caregivers struggle with this because it can get very frustrating, and they have this mindset of the resident or my loved one, they know what they're doing. They knowingly are resisting me and purposely trying to upset me or hurt me. And we really have to try to, although it's hard, get away from that and remember, this is a person that has cognitive loss, has cognitive deficits. They can't communicate. They're trying to tell us something, that they're in distress. I'm not going to go over all of this, but when you're dealing with behaviors with dementia, your goal as a caregiver is you really want to, you become that detective. You need to try to figure out what they're trying to communicate to you. And as healthcare professionals, what we really do is if we have somebody with a behavior, we try to break it down and look at these 4 different areas. We look at medical need, personal need, caregiver need, and environmental need. Medical need, we always go to that first. And again, I'm not going to go over this complete list, but if a lot of times somebody might simply be having a behavior because something is medically wrong and they can't tell us that. I always go to the UTI, the urinary tract infection. All of you maybe have experienced maybe someone with a urinary tract infection. You know that when they have one of those, they can be completely off, completely confused, delusional, and that can lead to all kinds of behaviors, things you wouldn't normally see with the person. But if you can assess it, get them on antibiotics, you can resolve that behavior pretty quick. If they're thirsty, if they're too cold, too hot, tired, all of that is going to spark potential behaviors. You got to look at the personal need. So depending on if the person's in early, middle, or late stage dementia, there are just typical behaviors that you see. Not because anything is wrong, but it's just very typical of that level of dementia. And it's just anticipating that you might see those, and then what can you do? What techniques can you use to help that? Wandering, like I said, is very typical. Hoarding, rummaging things, packing up their bags, that's very typical. I want to go home, trying to leave, that's typical. Repeating stories and questions, you're going to start to see that a lot in the middle stages. And urinating in inappropriate places, that's most typical in the late stages. So it's then applying different ways of managing those behaviors. Past memories, that's huge. So if somebody went through horrible abuse, or maybe, we have these veterans that have went through the war and they might have behaviors such as that. I had a resident who was in the Vietnam War, and he had food rations from the Vietnam War still in his room that we found, and he was having behaviors. And so we were maybe thinking, was he being reminded of his involvement in the war and memories of that, and was that sparking agitation or anxiety? So any kind of past memories can do that. When we have somebody with a behavior, we really have to look at the environment. I would say the environment can be one of the largest contributors to behaviors. When you have too much noise or not enough noise going on in that person's environment, that can play a huge role in behaviors. TV, I get a lot of questions from family members. Well, can I bring a TV in for my loved one? And again, that's a very individualized decision based on where that person is at. But a lot of times, I could give an 8-hour talk on TV and dementia and how it can really be negative or detrimental to a person with dementia. With TV, you turn on the TV, especially these days. What's on TV? There's not a lot of positive things. It's a lot of negative stuff. And you and I, even you and I, who are cognitively intact, we have a hard time dealing and coping with what we see on the TV these days. Not to mention somebody that has dementia where they can't really make sense of it. So it can cause a lot of anxiety, a lot of agitation. So really that TV, no TV, our programming that we do at Emerald Crest, we don't just turn television shows on. If we use the TV, it's for whether it's sing-alongs or trivia games, it's very specific activities. We try to stay away from it. Having that daily schedule, so a routine where they do certain activities throughout the day versus having nothing and all this downtime, that can spark behaviors if you don't have enough structure. Like I said, having a very clean room versus a cluttered room, that can cause behaviors. That caregiver need, that last area, whenever you have a behavior with somebody that has dementia, you really have to look at yourself as the caregiver. Were you using the right approach? Or maybe you were giving them too many words or not enough direction and it was causing agitation. Again, that tone, your body language, they can pick up on those things. Your tone of voice, I've talked about that forever. Ability to let go. I always touch on this because I have caregivers that really struggle with this. With my kind of early middle stage folks, they really have no impulse control. They have no filter. So if they're thinking something, they just say it. You or I, if we see somebody's gained a few pounds or maybe you don't care for their hairstyle or the outfit they're wearing, we know that we just don't go up to the person and say we don't like their outfit. We know to keep that to ourselves. Somebody with dementia, they'll just say it. Or they'll say, hey, it looks like you're gaining a few pounds. They'll just come out and say it, and they don't have that filter. So I have to teach my caregivers, although it can maybe come off as hurtful, we really have to just let it go. We have to remember they have dementia. They have cognitive loss. They have a disease. Making that eye contact is huge. Like I said, using too many words or enough words, all of that and how you approach them, how you communicate with them can spark behaviors. So the care partner, if they're really kind of closely looking at those 4 different areas, they really can kind of start to look at the behavior. So if you see a lot of red flags when it comes to, oh my gosh, it's how I'm caregiving, it's how I'm approaching, I use too many words, or I did this or I did that, you can really kind of focus in on a specific area and then go and work with that as far as helping to manage or decrease that behavior. And it really has a lot to do with listening with your ears and eyes. So like I said, it's really being that detective and observing what that person is doing. And if those 4 areas that I talked about are unbalanced in any way, so let's say you've identified some issues in the area of caregiving and approach, that's what you want to try to affect in order to help manage the behavior. And really, I can't sit here and say, well, this is how you fix this behavior, and this is how you fix that behavior. behavior management with dementia is really a trial and error approach. And what works for one person maybe to get them in the shower might not work for the other person. I can say, well, if they're at this stage, sometimes this might work, but it doesn't mean it's going to work every time. It really takes a lot of perseverance and persistence. And I would say it's probably one of the most difficult things when it comes to caregiving with dementia. But how do we measure the success of our care when it comes to caregiving at the end of the day? Well, look at these key areas. Monitor, do you see a decrease in a loved one's behaviors? Now, I will remind you, you might not be able to completely rid a person of a behavior, but your goal is, can you reduce how frequent or how intense that behavior is happening? Now, if you're able to have pretty smooth days and actually be successful with completing a person's cares, I would say you're having success with your caregiving. If your loved one's demeanor is stable, they seem content, they seem happy from day to day, you're doing something right. Yourself, your family, and your loved one are satisfied. So if, like I said, if everybody as a whole, you included, are not feeling stressed, overwhelmed, feeling pretty content, feeling pretty good about things, you're doing something right. You're doing things right. So just to end for the day, dementia care can be challenging, but having an understanding of the disease process and having some tools and tricks in your back pocket can make it more successful and rewarding for you. So that's all I have today.
Thank you so much, Jenny. Wonderful information. So at this point, we'll open up the chat room for anybody who has questions. You can go ahead and just type them in there. I will then keep an eye on that chat room, and I will address those questions. I know as I was monitoring the chat room just a little bit during the presentation, there was a question about having a copy of the video of these presentations, and yes, we will be doing that. Just takes a little bit of time for our tech people to put it on our website. Once it is up on the website, I will send out a link to everybody who is signed up to go and view that and share it if you would like to. So we'll wait a minute or two or a few seconds here for questions to come up on the chat room. So feel free to go ahead and type that, and we'll address them as they come up. All right, let's wait just a few more seconds. If we don't have any questions, we'll end. All right, we do have one question here. It says, I am working with a patient who's very angry and belligerent. He has no insight regarding his need for care. So maybe any suggestions, that's where she ended her comment there, any suggestions on maybe somebody who is not understanding they need help? She did add here, whoever his wife does not feel she can continue to provide care. So maybe helping to address a situation where maybe somebody doesn't understand they need care, but they do. Any recommendations with that?
That's probably one of the hardest behaviors to deal with because you know they're at a level where they don't have the reasoning ability, they don't have the you know, they don't think anything is wrong with them. You know, again, I don't have, you know, do this and that'll help, but I would say as much as you can make this individual feel like they still have control, because my guess is they're feeling like they're losing control and that they have no say. And so as much as you can make them feel like they're still in the driver's seat with, and at the same time, providing that supervision they need, I guess, is key. A lot of times when I have people like that, what I try to do is give them choices. You know, if they need to take a shower, you know, is it, you know, well, we've got to get a shower done today, but would it be easier to do it in the morning versus the evening, or before breakfast or after breakfast? Trying to give them choices in what you are trying to help them with. A lot of times if they're belligerent like that, I will just kind of use the authority, you know, going back to the doctor, using them as kind of the scapegoat. Christine, I don't know if you've got any other recommendations. That's a tough one.
That is a tough one. The only other thing I can recommend, and maybe you mentioned this because I was busy responding to somebody in the chat room, is, you know, if they do well with, you know, listening to what the doctor says, or somebody of authority who says something, maybe church. I've seen, you know, a church nurse or the pastor have good relationships with that individual, having that individual maybe try to reach out to them and guide them. All right, couple more seconds here. A lot of good comments, Jenny, about great information, so thank you for doing that. One of the questions was, is social work a part of our services? We do not have a social work within Emerald Crest, but we do within CASIA. So, you know, if we can't manage through the individuals we have at Emerald Crest and need more support with social work, we do have access to that. Okay, I think we will end. If you can believe it, Jenny, we actually ended in less than an hour and a half. So thank you all for joining us. And again, I will reach out via email to all participants with the video recording available online when it is available, and handouts and CEUs as well. Please give me about a week to get that prepped and sent out. And if you still don't hear from me, feel free to pop a email out to me with a reminder. So and make sure you get that. So thank you so much, everybody. Thank you, Jenny, and have a great rest of the week.